Is Dr. Amit Kaul, who's going to speak on meta-analysis studies looking at staple versus fibrin glue mesh fixation. So I guess we've gone from none to polygalactic to now we're going to use fibrin sealant.
And I would like to thank the moderators and SAGES for allowing us to present our data. I have nothing to disclose. Laparoscopic repair of inguinal hernia has been around for the last 2 decades, and the main advantages purported being lesser postoperative pain, early recovery, and return to normal activities, as well as better cosmesis. But these very advantages are marred by postoperative groin pain syndromes, which occur anywhere from 9.5 to 22.5% of the cases, and as long cost, which is more. This made the surgeons think of alternatives, and the first one being whether the mesh needs fixation at all. But the concerns remain of mesh displacement as well as recurrence. The other alternatives being use of non-traumatic, non-tissue penetrating modes of mesh fixation like cyanoacrylate glue and fibrin glue. But the cyanoacrylate glue has its own problems of polymerizing quickly during the operation and hardening, and has the chances of the instrument sticking to the tissues while the operation is being performed, which can be dangerous. As well as there are some reports of cytotoxicity of using this glue, and as such, FDA never approved this. So we are left with fibrin glue of human origin, which has otherwise been used for many other purposes in the human body. But the concerns again remain whether these modes fare as well as the mechanic fixation. To address this, we did a meta-analysis to compare the traditional mesh fixation with staple or tacks with fibrin glue fixation, with the primary outcomes being hernia recurrence and postoperative chronic pain, and secondary outcomes being seroma formation, hospital stay, return to normal activities, and operating time and cost. We did the literature search using the PubMed search engine, and the last search was done in December 2010. The following search string was used. This led to us a total of 30 studies, and putting the inclusion criteria, which were the studies had to be of only total extraperitoneal repair and had to compare mechanical fixation with the fibrin glue fixation and had to be in humans. Putting these criteria, we were finally left out with 4 studies which were included in the systematic review, and out of these, 3 were finally included in the meta-analysis. We did pooled analysis for the outcomes recurrence, chronic pain, and seroma, and I would like to summarize all these within this summary pooled analysis slide. And as you can see, the only outcome out of the 3 which is statistically significant is the chronic pain. Now the x-axis here denotes the odds ratio going more towards the right side, and odds ratio of more than 1 going up signifies the more chances of the event, that's the chronic pain, occurring in the previous group, that's the staple fixation. That means the staple fixation had an odds of 4.5 times of having chronic pain as compared to fibrin glue fixation. The rest of the 2 outcomes, recurrence and seroma, were not statistically significant. As you can see, the confidence intervals are overlapping 1. The secondary outcomes, seroma, as seen, was not statistically significant between the 2 groups. The length of stay, no difference. The surgical time, no difference. The cost is one important issue. In the 2 studies in our finally included studies reported that, and one of the studies by Novick et al. Reported for unilateral hernias, the cost was not different, but for bilateral hernias, the fibrin glue costed around $100 more than the staple fixation. But the other study by Lau et al. Reported actually that fibrin glue fixation costed nearly double the cost of normal staple fixation. To conclude, we can say that glue fixation can be as good as mechanical fixation in terms of recurrence, but has a lesser incidence of chronic pain and no significant difference in operating time and hospital stay. And the cost can be an issue, which can be eventually the deciding factor for which mode of fixation you will go for, and which may be dependent on the amount of glue you use. I would like to thank my mentor, Dr. Michael Marone, and the rest of the members of my study team. Thank you.
I have a question I'd like to ask you. Fixation is certainly one source of inguinal hernia pain that's been reported, and another one that's been discussed recently is the difference between lightweight mesh and heavy mesh.
Sure.
I'm wondering if you accounted for differences in mesh use in the studies you reviewed.
Yes, so we would definitely like to report that, but the thing is that this is in meta-analysis, and the studies which finally made up into the final inclusion were all of the same mesh type, that was polypropylene, and we could not really assess this quality. But to add to that, I would say that it has been recently reported that if you use thin meshes, actually the amount of glue to be used can be less, and that could cost less cost to the advantage of the surgeon. So that's a factor which we'll, but to the study, we cannot have that.
Thank you.
Any other questions? Go ahead, Brian.
Brian Duncan from Houston. Really enjoyed the presentation. I know this is a comparison between tax and glue, so this might be a little bit outside of the scope, but there's a lot of data that suggests you don't need to do anything. And I wonder how your glue compares to that group, if you know that at all.
So I cannot compare glue to the fibrin because that's what we did not look, but as of last year, I actually presented a study in ACS looking into fixation on non-fixation totally. So I found, again, there was no difference in that. But to address to your question, glue per se, I would say it's a very good option to compare. Like if the cost is not an issue, it can be used, but to compare with total non-fixation, we did not address to that because, as you can see, to look into these aspects of glue versus traditional fixation, we could only land up in 4 studies, and I bet there is none there existing which compares glue with no fixation at all. So this will be very interesting to look into.
Did your meta-analysis give any indication on tax, on how many tax? Was it a wide range or just them are mentioned?
No, actually, they all said about the sites to be tagged being the Cooper's ligament, and some used the lateral tags, but the numbers were not like the main emphasis. I really can't comment on that because it's the data.
Thank you.
Thank you.
Thank you very much.